America is home to 33 million small businesses, the beating heart of communities across the country.
And proof that the American dream is still alive.
This is a show about those dreamers and doers and the communities they serve.
Their real life stories.
Their struggles and successes.
Their grit, determination, and passion.
And the people who fight
to keep their American dream alive.
I'm Alfredo Ortiz.
I'm Elaine Parker.
And it's time for another episode of Main Street Matters,
America's small business megaphone.
Hi, and welcome to Main Street Matters, America's small business megaphone. I'm Elaine Parker, the president of the Job Creators Network Foundation, and I'm flying solo today. So if you want to subscribe to the show, you can subscribe at SalemPodcastNetwork.com or wherever you get your podcast from. So today we're going to be joined by Dr. C.L. Gray. He's a nationally known writer, speaker, and board-certified physician practicing in a hospital in Western North Carolina. And in 2006, he founded Physicians for Reform, a nonprofit organization dedicated to preserving patient-centered healthcare. CL is also, Dr. Gray, I should call him, he is also a great friend to Job Creators Network, and he also sits on the board of the Job Creators Network Foundation. Just to give you a little bit of background about Dr. Gray, we started working with him about 4 or 5 years ago in developing a plan that we could bring forward. He's been in this space for 20 years from a doctor's perspective. He understands the policy, but he also understands, obviously, the patient impact of what he's seen over the course of the last 10 years with Obamacare. But he does not think the system was working before Obamacare. We had a broken system before Obamacare, and Obamacare simply took a broken system and broke it more. And so I love his perspective. We developed together through both organizations. We did the largest study of Americans to find out what they wanted. We did market research of about 30,000 American voters about what they wanted in a healthcare plan. And from the inputs of that study, we developed what we call Healthcare for You, which is a healthcare framework, a policy framework that puts patients and doctors back in charge of healthcare decisions. It gets the bureaucrats and the red tape out of the exam room and out of the decision-making process. And it creates a more vibrant marketplace system where we have more choice, more competition, and more transparency of costs, all the while making sure that pre-existing conditions are covered for all Americans, helping to reduce the malpractice exposure that drives up those costs for physicians, and helping patients understand that they can be in charge of their own healthcare decisions. And so I'm excited to have him talk about, sort of the practical implementation of aspects of Healthcare for You. We just need to get the federal government to actually move forward on healthcare and help Americans understand that as long as we keep going down that road of more government control and towards that, marching towards single payer, we're going to be in big trouble, because when you look at countries like the UK and Canada, they have tremendous wait times, and that is called healthcare rationing. That's how we ration healthcare, is by making people wait to get care. And we're seeing that more and more in the United States, but we don't understand how bad they suffer. There's over 4 million people in the UK waiting on a wait list for care, over 1 million in Canada. We don't want to be there. We want to fix the healthcare system. And the way to do that is by removing costs, removing the complexity, getting rid of that top-down government approach that treats everybody the same, because healthcare is very personalized, and it should be, because it's personal to you and me. So let me introduce Dr. Gray, and we can talk more about everything he's working on. Dr. Gray, now his book is now in its second printing. It's called The Battle for America's Soul. So if you haven't read that, please get a copy of it and read it. And it resulted from a decade spent in research and analysis of the history and philosophy of medical ethics. The book presents findings that link America's cultural divide with the practice of post-hypnotic medicine. Dr. Gray, welcome to Main Street Matters, America's small business megaphone.
Elaine, so good to join you. Thanks for having me.
It's great to see you. We've been working together for so many years now on healthcare reform. We thought it would be just a great opportunity to have you on to talk about free market healthcare, what you're doing in this area. We've talked about healthcare for you in the past, and what that means for Americans, what it could mean for Americans. But I saw this article last week that said US employers expect to see the biggest jump in healthcare costs in a decade next year. And all I think to myself is, Obamacare is not working. The purpose was to bring down healthcare costs, and we're going to see the largest increase after a decade. And it's one of the biggest costs that our small businesses suffer with. And I go back to everything that our federal government misses on, and that's getting to the root cause of these problems. And with healthcare, it's the cost drivers. And so that's why I thought I have to have you on. I have to have you talk about this with our audience because no one knows it better than you.
Yeah, Elaine, you're so right. Since the passage of Obamacare, premiums have doubled, deductibles have tripled. So even though they have insurance, I'm a practicing physician in hospital medicine. So many of the patients I see are functionally uninsured because they can't afford their copays. So one of the primary problems is all the middlemen standing between the patient and the physician. So as the costs are going up, it's becoming more and more tempting for the average American, maybe the average small business owner, just wishing government would take over the whole thing. But what that does is it injects yet one more really big middleman that stands between the patient and the physician. So the solution is reconnecting patients and physicians, getting all the middlemen out of the room. So we can talk a little about what that might look like and what the primary drivers are. But I can understand the pain of the small business owners when oftentimes it's their second largest line item for health benefits. They simply can't afford these skyrocketing costs.
Yeah, I mean, I read that, and in my work with you, I've read that the average healthcare premium for a family has risen about 174%. 174%. And yet, Democrats in Congress continue to tell the American people that Obamacare is working. And I actually believe that the admission that it's not working is that they continue to ask for the subsidies and increase the subsidies and keep them going. Because if they weren't paying subsidies to Americans to buy Obamacare, nobody would be able to afford it. Absolutely nobody.
Yeah, and it's a great point because there's so much hidden cost because it comes as a quote benefit, oftentimes with employment. I had a friend that recently left the White House, and he went and was looking for health insurance. He's spending $16,000 a year for coverage, and that includes a $6,000 deductible per family member. He has a wife and two kids. So he has a total exposure of approaching $40,000 annually. And that's just not sustainable for the average American.
Yeah, that's like being uninsured. And my past history. I've been talking this talk for so long that I decided to actually walk the walk. And I went to direct primary care, which I've talked about on the show before. That is basically having a physician that is opted out of the insurance
Hmm.
plans, and basically it's a cash basis. It's like like a gym membership, really. But I can message my doctor. I can get an appointment very quickly. I feel like it's my doctor and I are making all the decisions. I mean, that's what we're missing is that doctor-patient relationship, along with the cost drivers, because you've said many times doctors are now more than half of them are employed by hospitals, and so they're beholden to the hospitals instead of to the patients. And I mean, I love to say let's remove the costs and let's get back to doctors and patients in control of the decisions, and most importantly, their healthcare decisions, but most importantly, the patients in control of their healthcare dollars. And how do we incentivize that? How do we bring in free market healthcare? And I know that you have worked 20 years in this area and trying to push forward alternative free market healthcare plan. that will help Americans and bring down the cost. What are some of the things that you're doing that you can talk about? I know it works in conjunction with our Healthcare for You campaign that we worked on together, but you're actually working on making it a real life. I call it a demonstration project, but most people will call it like a pilot program.
Yeah. And I think back to our research from, 3-4 years ago when we did some of the largest marketing research in healthcare in the country. And what we found back then was what Americans of every stripe, left, right, doesn't matter, age, sex, or race, Americans want access to high quality care that's affordable and working with a physician they know. They don't want bureaucrats. They want access to true care, but that care has to be affordable. So what we found, it was interesting, a couple of years ago, I was hosting some national physician leader conference calls. And I was interviewing many of the different physician entrepreneurs around the country. And it was interesting. I interviewed a friend from Texas that's developed a direct patient pay for imaging. She's able to, using a direct pay model, to cut the cost of CTs, MRIs, X-rays by somewhere around 50, 60, or 70%. I interviewed somebody in primary care. Same thing with a direct primary care model. Again, that cost is markedly reduced, 50, 60, 70%. I interviewed a specialist that did direct patient care. Again, dropping cost, 50, 60, 70%. So that's true for independent surgical centers. It's true for specialists. It's true for primary care docs. It's true for supply chain. What I saw was in interview after interview after interview, when we take out the middleman, let the provider engage the patient directly with a cash paying system, you can radically reduce, in some of the labs and imaging, you can reduce costs by 95% by getting rid of the middleman. So what I'm working on now is to develop a platform and working in partnership with Job Creators Network, so we can start to pair patients and small business owners with this cash-based system. And if you don't have a plan for catastrophic coverage or large medical expenses, I say you really don't have a plan for healthcare. So what we're doing is we're bringing the medical cost sharing model that handles the large expenses. We cut the cost approximately in half. This makes it much more affordable for the small business owner and by extension their employees.
So practically speaking, are you talking about setting up a plan where a small business contracts with, say, a direct primary care doctor, or many of them, and employees can choose and who they go to for their primary care needs, and the doctors fund, say, a pre-tax account for employees to pay for that cost, and then on top of that you overlay a catastrophic plan to deal with heart attacks and the major stuff, cancer, things like that.
Yeah. So essentially, I'm trying to build this out as sort of a modular system, starting with the large medical expenses and then bringing in the direct primary care. Sometimes that's direct, as in the office primary care or virtual primary care. There's a lot of medical needs that can be done virtually that's far more efficient than an office visit for every UTI. So, and then once we get the large medical expenses and the primary care piece covered, then we can bring in the imaging piece, which should be pretty easy to do. Then we can bring in the specialist piece. Then we can bring in the surgical piece. So, in each time we add a free market piece to the system, it brings down the cost. And of course, there are people making tremendous sums of money, like the middlemen in the healthcare supply chain. They siphon off between $200 and $250 billion a year in kickbacks. So there's a lot of this money being siphoned out of the system, and they're not going to be happy about a true competitive, fully transparent alternative healthcare ecosystem. But we'll start with the individuals and the small business owners, because the large systems aren't that interested in the small business owner. But that's a perfect place to run this pilot to prove that it works, every time we've tried this on a sort of a local basis, it's worked extremely well. Now it's starting to put the pieces of the puzzle together and actually build out a system where patients can enter that system and feel that they're cared for. Because that's one of the things that's preventing true transformation in healthcare is patient fear. They say, boy, if I go here, am I actually going to get my care? So once we prove that they still can get care, then I think patients and business owners are going to rapidly move to this alternative system because you get better care, better outcomes at approximately half the cost. And the cost savings comes from cutting out the middleman. So it's not reduction in quality. That's another sort of fascinating thing that I've learned. There's almost this inverse relationship between cost and quality. Oftentimes, as cost goes up, quality goes down. In our kind of normal everyday experience, we think, well, if I'm shopping for a car, if I spend, $50,000 on a car, it'll be a vastly better car than if I spend 10. But in healthcare, almost the opposite's true. So there's a way to decrease cost, increase quality, increase access, and have better patient outcomes.
I mean, I understand it. And because I've been doing this, for so many years with you, and I understand it
Mhm.
from the policy perspective, and I understand it from the patient perspective because I've experienced it myself, and I believe in the system. But one thing that I think our side sometimes doesn't do as well is package it up in a nice little package that Americans can understand and go in, and that's that fear you're talking about
Mhm.
is and Obamacare was pretty and it was simple. I mean, remember how President Obama sold it. If you like your doctor, you can keep your doctor. If you
Mhm.
like your plan, you can keep your
Mhm.
plan. I mean, all of that turned out to not be true, but it sounded so simple.
Yeah.
And,
Yeah.
all it's done is drive up costs. And we have to figure out a way to package things. We've both heard Alfredo talk about how Democrats are so good at selling the front of the
Uh,
Diet Coke
yeah.
can, right? They
Yeah.
sell
The front
the
of the can.
Diet
Yeah.
Coke, happiness,
Mhm.
happiness light in a can. And Republicans sell all the ingredients, the back of the can, the
Mhm.
ingredient statement. And I can't even pronounce half the words that are in the ingredients of Diet Coke. Um, but we have to figure out how to package it. And that was part of how we came up with healthcare for you. And it was to compete against Medicare for all. Do you want Medicare for all? Which is big government, no choices, very expensive, top down, one size fits all, or do you want healthcare for you, personalized healthcare, where you get to pick your plan and pick what you need, and there's more cost transparency and more choice, more competition, and I think that was a great first start. But practically speaking, how do we get Congress's attention to actually want to move forward and tackle these middlemen? Because the middlemen in the pharmaceutical industry, the pharmacy benefit managers. I mean, these are forces that are
Mhm.
tough to reckon with, and they're very powerful and they're very well funded.
Yeah, I think it's going to have to be sort of a two-pronged approach. There's some things that I think we actually can make progress with in Washington, such as expanding HSAs so patients have more control over their dollars and more freedom with how they use those dollars. That's going to be a legislative piece. But then I think in terms of dealing with the middlemen, and there's so many of them all over, it's not just the PBMs and GPOs, it's the hospital systems, it's the insurance industry. It's interesting, there's a medical loss ratio, a concept that most people have never heard of. But the insurance industry has to spend 80% of their essentially revenue on patient care. So to increase their profit margin, they like to see the costs go up. That's how they grow that 20% that they can keep for overhead and profit. They can't expand that 20% legally. So the insurance industry has an incentive to see costs go up because of the third party payer system where the cost of care comes as a benefit with your job. The average American is blinded to the ever escalating cost. That's why we haven't seen real wage growth over the last 10, 15, 20 years, because everything that would be normally seen in a fully functioning economy that would be seen as wage increases is being sucked up in health benefits. So the employer is spending more money per employee, but the employee doesn't see that as increased wages. They see that as increased costs of healthcare.
Right, right. So let me get this straight. The insurance industry is incentivized to increase the cost of healthcare,
Yeah.
but
And that's
employee.
balanced a bit by competition. If you have your BUCAs, the Blue Cross, United, Cigna, Aetnas, they have to compete with each other to a limited degree. But they've already captured essentially 100% of market share. So they really can't grow their market share. So the only way they can increase revenue is by letting costs go up. And that's blinded to the American public because it's going up in health benefits. They're not paying for it. So because the American citizen, the employee, is blinded, and same for Medicaid, Medicare, but that's slightly different, is blinded to the true cost of care, it's skyrocketing, and
Well,
Americans are
yes,
suffering.
yes. And so I was thinking I was kind of going down the road of incentives. So insurance companies are incentivized
Mhm.
to increase costs, and Americans, employees, and their families have no incentive because they're blinded. They don't know what healthcare
Mhm.
costs are, and because there's no transparency. They have no incentive to actually look for better pricing, I guess is the best way to
Yeah,
put it. Not that you go
absolutely.
shopping for a new heart or anything, but
Mhm. Well, in some ways we should, because there are centers of excellence that are beginning to move towards a fully transparent, cash-based, pay upfront model. Now, if we can move the dollars from the government or from the insurance industry back to the individual, which is really at the heart of what I'm trying to do, is get the patient back in the driver's seat because they control their healthcare dollar. Now they begin to ask, how much does it cost? And do I need this test? As soon as we re-inject those two free market forces back into healthcare, then we'll see quality go up and costs come down. But that's really the, the basis of the real solution is to get patients back to being active consumers of healthcare instead of passive consumers where somebody else is. It's the difference between first party payment, second party payment, and third party payment. In a first party transaction, I'm buying something for me, whether it's a car or a pizza. I care about cost and I care about quality. Second party payment is if I'm buying a present for somebody else. I care about cost because I'm still paying for it, but I'm not so sure about quality. If they're happy, I'm happy. So a third party payment is where I use somebody else's money to buy something for a third party. In that system, I don't care about cost and I don't care about quality. That's American healthcare. So the solution is to put the patient back in control, turn it into a first party payer system. Then cost goes down and quality goes up. And patients have more freedom. And that's the most important point. Then patients have the freedom to make their own healthcare decisions. Because as soon as we offload the payment to somebody else, whether it's the insurance industry or government, somebody else is making those decisions. In the hospital, I see this time and time and time again. I say, well, you didn't meet criteria. You didn't get approved for this. And then because a third party payer is making that decision, then the patient and their family is stuck saying, boy, I couldn't pay for that by myself. So the third party payer controls the medical decision making as opposed to the patient physician.
Mhm.
That's the piece that has to change.
Right. Now on the transparency part, these cash basis direct medical care facilities that are popping up,
Mhm,
it's from x-rays to MRIs to
mhm.
orthopedic surgeons. primary care. I mean, we're seeing it happen. But when you get into having to get a new knee with an orthopedic
Mhm.
surgeon, even if you're doing cash basis, those are some big ticket items that people
Yep,
may not have the
yep,
money laying
for sure.
around. Even if the cost comes down tremendously under what they would have paid in that annual
Yep.
deductible that they have to meet. So let's say they have a $25,000 a year deductible, not unheard of,
hmm
but they can get a cash pay surgeon, a very good surgeon, which I know of one in Georgia,
hmm
to do a knee surgery for $12,000. That's a massive savings. But your average American doesn't have $12,000 laying around,
Yep,
even though
for
it's a
sure.
great
For
savings.
sure.
So where does the medical cost sharing come in? How does all of that factor in?
Yeah, so then instead of traditional insurance with these large deductibles, the medical cost sharing model has developed a mechanism where there's instead of calling it a deductible, they call it initial uninsurable or unshareable amount. So that can be set between 500 to 1,000 or $1,500 per incident. So if you need a knee replaced, if that would be your expense, anything above that expense is shared by the cost sharing community. And in old language, insurance, but it's a non insurance alternative to cover these large expenses. Now it's in their interest, medical cost sharing world, for their patients to go to these lower cost, direct pay, cash up front, high quality providers. So you know in advance it's a high quality service, but you know the cost. Oftentimes that cost will be a third to half of what the insurance would tend to pay. So as more patients are directed towards these cash-based, fully transparent providers, the costs are going to come down for the community. As costs come down for the cost, medical cost sharing community, their sort of premiums or their uh, monthly contribution goes down or at least stays flat. So we're working with a hospital in Florida where we've started to implement this model. In the past, I think it's 5 years that they've used this model. They haven't seen any increases in their premiums. It's not using medical cost sharing, it's a different kind of structure. But by having fully transparent cash upfront services, they've been able to hold their cost for their employees completely flat. So imagine that if the average employer said, boy, I haven't seen any increase in my healthcare cost in the last 5 years. So that's the kind of thing we can do. And eventually there will be inflationary pressures. But by dealing with this tremendous waste and abuse in the healthcare system, we can cut the cost, deliver excellent quality, and make it affordable and accessible for the average American.
We've got a couple minutes left. I want to spend a little bit of time talking about pre-existing conditions. It's one of the areas that Democrats always talk about Republicans fall short on, and that's covering
Mhm.
pre-existing conditions. You've talked about this a lot from a doctor's perspective on pre-existing conditions and policy. So I wonder if you can talk about how we cover pre-existing conditions because that's so important to especially Americans who have,
Oh, yeah.
diabetes or
Yeah.
previous cancers,
hmm
things like that.
Yeah. And it's sort of like if you can't deal with large expenses, you don't have a plan. If you don't deal with pre-existing conditions, you don't have a plan. So again, because I'm an internist, I go back to sort of root problem. A lot of the quote pre-existing condition problem is because of the structure of our system. If you switch employers or lose a job, you lose your health care coverage. So that means you're not covered. So the next time you try and get coverage, you've got a gap. Now, what was just a normal condition all of a sudden becomes a pre existing condition because the diabetes was covered under the old insurance and they care for the diabetes. Now, when you apply for new insurance, they say, oh, you've got diabetes. Well, it turns out you've had that the whole time. It's just you had a gap in coverage. So, on the policy level and sort of broader strategic level, if we can design coverage that follows the patient, Like if you switch jobs, you don't lose your car insurance, but you do lose your health insurance. So if health insurance was affordable and personalized, so that would move with the patient and their family when they switch jobs. And if the cost was affordable so they could maintain it in between jobs, then you wouldn't have a large portion of what's being considered pre-existing condition. Then there are a few cases that, for whatever circumstances, sometimes it happens when a young, healthy gal doesn't have insurance, then she gets pregnant, and that's considered a pre-existing condition then. So sometimes,
Imagine that.
yeah, it's amazing. Yeah. But then I was working with somebody out in Missouri, and what they had done is they, at that point, called them high-risk pools. So just if somebody didn't meet criteria to get insurance, and I think the criteria there was they had to be rejected by 3 insurers. They had to go to 3 insurers and not get coverage. At that point, they would qualify for the state high-risk pool. We can change that language because no patient wants to be considered a high-risk patient. If just because you're pregnant doesn't mean you're a high-risk patient. So it could be just something called the guaranteed coverage pool. So if there's a guaranteed coverage pool operated by the state, oftentimes in this particular state, I think that the charge for the premium was 150% of baseline. So there's an incentive to keep your coverage because you don't want to pay time and a half if you don't have to. But that would make it available to people that did fall in this pre-existing condition box. And then over a period of 1 or 2 or 3 years, that pre-existing condition just becomes a quote condition. And then you can qualify for the regular market. So that's one kind of solution. The way Obamacare dealt with it was they said insurers can't look back at previous conditions. So there's sort of automatic coverage. What happens with that then is you incentivize patients to not worry about healthcare until there's a crisis. So then you have people moving into the system with tremendous financial need, and that's going to break the system. Insurance isn't designed to pick up. It's like the idea of only getting car insurance after you've had your accident. The American public thought about that. It's like, there's no way.
Because you can sign up for
would stay
Obamacare.
affordable.
You can sign up for Obamacare. You can go
Yeah,
without insurance
even
and
after
pay
you,
nothing, and then get a cancer diagnosis and sign up for Obamacare and have insurance, right?
Yep. And then the average American could understand what would happen to the cost of car insurance if people were allowed to drive uninsured until they had their accident. The cost of insurance would skyrocket if that was the playing field. But somehow we expect it to work for health insurance, and clearly it won't. And that's part of the reason we're seeing these huge inflationary pressures, even under Obamacare, even though they're subsidized by the American taxpayer.
Yeah, we have to really help Americans understand that the UK and places like the UK and Canada, Americans are not getting, those people in those countries are not getting care in those countries. And there are wait lists. In America, we call them just delays. In other countries, it's called healthcare rationing. And care is very restricted in those countries. The wait lists are very long. In the UK, it's over 4 million people on wait lists waiting for some kind of care. In Canada, it's over 1 million people. Right now, Americans wait on average to see a specialist about 20 days. Can you imagine if you were told you had to wait 146 days like you do in Canada, or 126 days in the UK? I mean, Americans wouldn't stand for it, but yet we continue to march down this path that is going to take us into those kinds of waits and more healthcare rationing. Like I said, right now, the code word is delay, but it really is rationing.
Yeah. And I had a friend that used to be a senior radiologist in Canada. His job was to look at the number of slots they had in their CTs and MRIs, look at the requests coming in, and then pick out the handful that they could actually service. And everybody else got bumped to the waiting list. And it was like that every day. So most of these people just simply never got their studies done. It's not that they had to wait an extra 3 weeks. They just never got them done. And there were cancers missed, there were adverse impacts and outcomes for these patients. And another orthopedic surgeon that's a friend of mine went to Europe, and he was astounded by the number of seniors he saw using canes and walkers. He said because they're not fixing their hips and their knees, so they can't walk.
Right.
So the outcome, because if we don't control the fundamental cost drivers, which Obamacare absolutely avoided. Now, I know we're getting close to wrapping up here, but one quick point. What Obama sold to the American public was access. He didn't deal with cost. He promised he would, but he didn't. Costs have gone up. The other way to approach it is deal with cost. As we bring healthcare costs down to where they're manageable, we're going to increase access because it's affordable. Right. And what's happening if we only, quote, deal with access under Obamacare, but never deal with cost, never deal with these fundamental cost drivers, it's still going to be very, very bad for patient care. And the only way to deal with it is rationing.
Yeah, that's unfortunate. Well, I'm glad that you're in this fight. I'm glad we're in this fight together. And I think that we can make progress if we can get our messages out and package it in a way that Americans understand, because they're not happy with the current healthcare system. They just don't know of any other option. So I'm glad we're doing this fight together. But thank you so much for joining Main Street Matters, America's small business megaphone. And thank you all for listening today. You can subscribe to the show at salempodcastnetwork.com or wherever you get your podcast from.